Good afternoon, everyone, and welcome to today's ECHO session. My name is Benita Arokiraj, and I serve as the Population Health Analyst and ECHO Lead for the Constellation Regional Collaborative, within which this ECHO session is housed. I'm joined today by some of my CRC colleagues who I will invite to share introductions. Sydney, would you like to go first? Because I can see you on my screen.
Yeah, thank you. I'm Sydney Fleming. I'm the Outreach and Community Engagement Specialist with the CRC. I'm also a community health worker. Agner?
Thank you, Sydney. Hi, everyone. My name is Agner Munoz, also a certified community health worker and serving here at the CRC as a community health specialist. Welcome, everyone.
Good afternoon. I'm Sylvia Coleman. I'm a strategy consultant with the Constellation Regional Collaborative. My background is in nursing and public health policy, and it's good to be with you all this afternoon.
Thank you, team. And we usually have Maxine Arena on the call. She's moving this week, so will not be attending today's ECHO session. Maxine is our program manager. So thank you for sharing your introductions. Sydney will be supporting the chat throughout the session, and I will just help facilitate the agenda and go through all our agenda items today. And if this is your first time attending, please stay till the end to fill out our post-ECHO survey to receive education credits. Thank you again for joining us today, and we're excited to dive into today's discussion. We will begin with introductions from our subject matter experts and participants, followed by a didactic and case presentation by Dr. Carmen Samuel-Hodge from UNC. We're very excited to have you with us today. After her presentation, we will have a brief Q&A session and discussion to help with peer learning and just share different information, especially based on the presentations we hear today. And we will end today's ECHO session covering some logistics about our upcoming session, the date, and then our post-ECHO survey. Let's go ahead and get started with introductions. Do we have our subject matter experts on the call? If you are here, I can't see you. Please feel free to come off mute and just tell us a little about yourself.
Hi, good afternoon. My name's Emily Ridley. I'm a clinical pharmacist based out of an internal medicine residency clinic within Prisma Health in Columbia, South Carolina. We serve primarily a low-income urban population, but we have a lot of rural patients as well here who travel. So I work with a lot of patients with hypertension and diabetes and have worked across our health system in quality improvement efforts regarding hypertension control. Also serve as a consultant with PAHO and the Hearts in the Americas program. I'm looking forward to the talk today.
Glad to see you today, Emily. Thank you. I
Hi,
believe
everyone.
Valerie's on the call.
Yes. Hi, everybody. My name is Valerie Perez. I am located in Orlando, Florida. I'm actually transitioning positions this week to a new position where I will be the training and capacity building manager at Youth Collaboratory. And I specialize in supporting youth and young adults within the homeless response system. And my work will be expanding now nationwide instead of just Central Florida. And I'm really excited to be here and hear about this presentation and continue to take this work back to my community.
Great to have you here, Valerie, and congratulations on your new role.
Hello, my name is Sherma Jack Brisso. I'm from Prince George's County Health Department. I'm a registered licensed nutritionist and involved in teaching and helping collaborate with other facilities on nutrition interests in our community.
Great to have you here. Thank you. And all participants, please take a moment to introduce yourself in the chat by sharing your name, employer or organization, and your position and credentials. This just helps us know who's in the room and creates opportunities for peer learning and connection throughout today's session. All right, and I'm not sure if we have other subject matter experts on the call. Feel free to interrupt me. I can't see who's on the call since I'm sharing my screen, but we also have Dr. Jeffrey Brutler, who did inform me that he's unable to make today's call. He's a practicing physician with a lot of experience in chronic disease management. We also have Honey Estrada, who is a community health worker and is a strong advocate for health equity. And then we have Doctors Donald DePetty and Daniel Lackland, both of whom are nationally recognized leaders in hypertension and cardiovascular health research and policy. And we just heard from both Emily and Valerie. So we're very, very grateful for our subject matter experts' ongoing contributions to the series and the broader work that they do for the Constellation Regional Collaborative. All right, so moving forward, we're excited to announce today's didactic and case presenter, Dr. Carmen Samuel-Hodge. Dr. Samuel-Hodge is a professor in the Department of Nutrition at the University of North Carolina Gillings School of Global Public Health, principal investigator of the Core Research Project, and evaluation core director at the UNC Center for Health Promotion and Disease Prevention, an adjunct assistant professor at Duke University School of Medicine, and embedded faculty at Granville Vance Public Health, a rural academic health department. And this is just a little bit of Dr. Carmen's exceptional bio. So Dr. Carmen Samuel-Hodge, if you're able to come off mute and feel free to share more about your research interests and background to get to know you.
All right, thank you. So I'm Carmen Samuel-Hodge. As Benita mentioned, I'm faculty here at UNC in the Global School of Public Health. I come from the Virgin Islands, so a lot of my research has dealt with diabetes self-management, and particularly in low-income and African American populations. And so after working 9 years in public health, I wanted to do research with participants who would normally show up to a health department. And that's why the research I do focuses on that population. So that's me.
Awesome. So I will stop sharing so that you can get started with your presentation and take it from here.
All right. All right. So thank you all for coming to this presentation, and I thank you for this opportunity to share about the Carolina Heart Alliance Networking for Greater Equity, or the CHANGE program. And it had nothing to do with this name. So this is a CDC-funded 5-year project focused on strengthening community clinical connections or linkages to improve population health. So here is what I plan to share today. I always start by providing some context. So I'll give you some context as to where we did the change studies and the populations that were involved, and also to look at what we wanted to learn about community health workers in cardiovascular disease risk reduction interventions. So CHWs are frontline public health workers who are trusted members of the community they serve. And so there's really an important role for them in public health practice. So after I give you that context, I'll tell you a little bit about the intervention used in the CHANGE study before I provide a summary of the 2 CHANGE studies, which included a feasibility study and then a larger main study that followed. So I will share both implementation and effectiveness outcomes from these 2 studies, which had a hybrid format. And I will end with key takeaways and then share some success stories, not case studies, to put a face on some of the CHANGE study results. All right, so North Carolina has a particularly high stroke burden and is part of the nation's so-called stroke belt. And in particular, the eastern part of the state And you can see those two hollow dots there. Those are the two counties, well, actually three counties, so Hartford County, Nash, and Edgecombe. Those are counties where the change study took place, but you can see they're in the eastern part of North Carolina. And this is considered the buckle of the stroke belt, where the stroke mortality can be 40% higher than the national average. North Carolina is also a rural state. It's actually has the second largest rural population in the US. And over 20% of the population self-identifies as African American or Black. And on top of all of that, the intersection of being rural and African American usually translates into higher stroke incidence and worse outcomes than white counterparts. So this is the context in which the change study took place. All right, in terms of community health workers, one of the things we know is that the Community Preventive Services Task Force recommends interventions that engage CHWs. They found strong evidence of effectiveness for interventions that engage CHWs in team-based care models to improve blood pressure and cholesterol. They also found sufficient evidence for effectiveness of interventions that engage community health workers for health education, as outreach, for enrollment, and for information agents. In particular, to increase self-reported health behaviors such as physical activity, dietary behaviors, and smoking cessation, all in populations with increased risk of CVD. But if you look at the studies included in the systematic review that generated these recommendations, most of the settings were urban. Of the 28 studies, 22 of them were in urban settings. And so there's a bit of an evidence gap, in particular for CHW-led interventions that focus on more rural populations, and in addition, those that really look to enhance community clinical linkages, especially among rural African American populations. So this gave us a good reason to actually do these studies to fill some of the evidence gap. All right. Before I talk about the two change studies, it's good to know that there were two prior studies conducted by research at the Center for Health Promotion and Disease Prevention that tested the effectiveness of the intervention that was used in change. And these are the two studies listed on the slide, Heart to Health and Heart Healthy Lenore Project. And so in both of those studies, they used the same intervention we used, well, an earlier version of the intervention we used in the change intervention studies. But both of these studies demonstrated effectiveness. And the Heart to Health was a randomized trial. And the second one also had a randomized component to it. And these populations were much larger than the samples used in change. The reason I mention them is because when we get to change, the study design differs. So we don't focus as much on the effectiveness of the program, but more so on the implementation outcomes, because the effectiveness has already been demonstrated in larger studies. For example, the Heart to Health study, that included 385 participants, and the Heart Healthy Lenore Project included 339. In addition to the larger samples, they had a longer follow-up. So for one, it was 12 months, and for the other, 24 months. So we know the program works. The question is, how do you implement it in real life settings and in rural settings? The dietary approach used for both of these studies is what we call a Mediterranean style eating pattern, but one that's culturally adapted for the Southeastern US food culture. So we tend to call it Mediterranean eating Southern style. The materials for this program were developed over years of research, And it includes not only the participant materials, but also a cookbook with culturally adapted recipes. The behavior change approach used in this intervention allows for counseling to be tailored to participants' readiness to make change. And so there's a brief assessment involved in each session that allows the counselor to tailor that conversation to the participant so that they can decide what they want to work on and select their goals, their action plans. And as part of that, we always include a component where community resources are provided or identified to facilitate the behavior changes. So that gives you an idea of what went into the change study in terms of programming. All right, so change, the intervention, as I mentioned before, it's scalable in the sense that it's not very intense. So there are four visits happening on a monthly interval. In the change study, those visits were home visits. So the CHWs went to the participants' homes, or they went to a location identified by the participant in the community. So you have four counseling sessions, and in between those four counseling sessions are 3 brief phone follow-ups. So overall, we're talking about sessions that last 45 to 60 minutes, and then that brief call that lasts anywhere from 10 to 15 minutes. And so we're talking about 7 contacts. And in the first and the fourth session, the CHWs will measure blood pressure and body weight. We kept our measurement really simple. And then the booster calls, which are the interim calls, they last anywhere from 10 to 20 minutes, and they are scheduled 10 to 14 days after after the session happens. So a total of 7 contacts. And the booster calls are designed to simply check in with the participant, follow up on the progress they've made towards reaching their goal, and do some problem solving if needed. So that's the purpose of the interim calls. So the total dose for this intervention is estimated at 4 to 6 hours over a 4-month period. So it's not very intense. In terms of the dietary pattern that I mentioned earlier, these are the 4 session topics. Again, it's modeled after a Mediterranean style of eating. We call it Med-South. And it includes affordable and familiar foods such as peanuts, peanut butter, vegetable oils, and recipes that have been adapted for traditional Southern foods such as hush puppies, collard greens, and barbecue. Med-South, in terms of the dietary recommendations, it really recommends or encourages people to have 2 to 6 servings of healthy fats daily, nuts and beans 3 times a week, at least 7 servings of fruits and vegetables, and a focus on oily fish, at least once a week. The physical activity recommendation for this program is consistent with guidelines for Americans of at least 150 minutes of moderate intensity physical activity weekly. The manual for participants in change is written in a conversational tone, and the reading level is between the 5th to the 6th grade level. Most of the manual focuses on nutrition, and these 4 sessions listed on the slide are in the order of greatest potential to reduce risk of chronic diseases. So you can see where we start with the healthy oils, then vegetables and fruit, the quality carbohydrates, then session 3 is really the things to watch out for in terms of how they're integrated into your eating pattern. And then 4 is the protein foods with a focus on fish. In addition to this nutrition section, we have additional nutrition information just regular things like serving sizes, meal prepping, healthy eating on a budget, those types of topics. So this is what the program content looks like. And again, we also provide information on physical activity. So I mentioned the brief assessments, and the brief assessments are important because of what it allows for who can give the program. So these brief assessments happen before each session. So this is just an example of the first one. So you begin each session with an assessment of current eating habits, and then it's followed by background information and then tips, and then goals, and then action planning. So the assessment tips and goals are all color coordinated. So when you look at the manual, all the things that go together have the same color. And if you look at this assessment, you see 3 columns. So the leftmost column is where the desirable intakes are. The middle column, responses there mean that could be improved in terms of your intake. And then the rightmost column needs the most improvement. With this system, it allows you to easily identify what the participant could choose as a goal for behavior change. But at the same time, it gives you an opportunity to give positive feedback in areas that they're already at the desirable range. And then the tips allow participants to make these changes, give them ideas for how to make the changes. And then, of course, there's a goal sheet. And this pattern is repeated in every session. The beauty about this particular assessment is that it allows anybody without a nutrition background to actually give the program. So that's why it's designed this way. All right, so the change studies. There were 2 studies, one the feasibility study followed by a larger main study. They were part of a 5-year funding from CDC focused on strengthening community clinical linkages. The sites selected for linkages included a federally qualified health center or community health center and a local health department combination in the same county, with a focus on rural counties in the northeastern part of North Carolina with a high stroke incidence and mortality. There are 3 phases to the study. It began with a formative phase, then the feasibility phase, and then the larger study. And with all funding from CDC, there's a dissemination component as well. We used the same hybrid implementation effectiveness study design for both studies, where again, the focus was on implementation and adapting the intervention for rural public health and primary care settings. And you see here the cover for our dissemination toolkit, and I'll give you the link for how to download that product. But again, after those 3 phases, the last phases included a dissemination component. All right, so community health workers provided the intervention for these 2 studies. We mentioned it was 4 home visits and 3 booster calls over 4 months. The sample population included adults 80 to 80 years of age and identified with CVD risk factors and residing in a rural North Carolina county. So our enrollment goal for this first feasibility study was 150 participants. And to be eligible, they had to live in the county or receive medical care in Hertford County. 60% of the residents in that county self-describe as African American or Black, and 26% of them live below poverty. These are the rates for when we conducted the study. And recruitment from the health department was done by the CHWs, and that aimed to recruit a community sample with risk factors for CVD, whereas the recruitment from the community health center included the electronic health record, and staff were the ones who recruited using that EHR to get patients referred to the study. And they focused on the patients with higher risk, so uncontrolled diabetes, high lipids, hypertension uncontrolled, or a previous cardiovascular event. And what we did was we engaged in a subcontract with the sites to fund the hiring of a full-time CHW for each of the sites involved in the study. And of course, there's training of the staff. So prior to the patient recruitment and the community sample recruitment, the research team conducted 6 days of training with the site staff and the community health workers. And of course, the training included typical things: study protocols, informed consent, participant recruitment, study site protocols, and in addition to training on the content for the intervention, as well as community referral resources. So for all of the studies with change, we created a resource manual that gave locally available resources that would be important for the lifestyle changes we were promoting. So in terms of our data collection, our implementation measures focused on reach and delivery fidelity. And for reach, we capture that with the CHWs maintaining a tracking log of the number of people they invited to participate and whether they agreed to, and if they didn't, their reasons why not. And then in terms of fidelity, we had an online system where the CHWs documented their delivery of the intervention, including the contact duration, the content covered, the goals set, the referrals made, and the disposition of the referrals given. In terms of effectiveness, we really wanted to keep the burden really low. So we only required blood pressure and weight measures at the first and the fourth session. And then the surveys were administered by UNC staff, and that captured the dietary behaviors and the physical activity behaviors. So for the feasibility study, the goal was to enroll 150 participants. We were able to consent 131, and of the 131 that consented, 105 started the program. And then 76 of the 105 provided follow-up data. So we had a 28% attrition for this feasibility study. About 88% of the participants were non-Hispanic Black, 82% were female, an average age of 62 years, and the majority had an educational attainment of high school or less. So this circles back to the reading level of a material set at 5th to 6th grade level. 56% were diagnosed with hypercholesterolemia and 79% with hypertension, and about 10% were current smokers, and the sample had an average weight of about 216 pounds. These are feasibility study outcomes. In terms of our yield, of the 346 interested persons, 131 were consented to be a part of the study, and that represents a 38% yield. The average counseling visit lasted about 76 minutes. And remember, these were home visits. And the booster calls on average lasted 15 minutes. In terms of the uptake of the program by participants, 80% of the planned visits and phone contacts were completed. There was a slight difference by site. So we had the health department participants completed about 86% of all the planned visits, while the community health center participants completed about 74%. So overall, we had 82% of home visits and 78% of booster calls completed. And the topics folks selected to be their priority for what they wanted to work on included mostly the healthy eating or nutrition modules, and then the physical activity, followed by medication adherence. So that's what they chose to focus on. All right. So that was our feasibility study. And the whole point of doing a feasibility study is to figure out which aspects of your program need a little bit of change or to enhance the outcomes in some way. So what we took from this feasibility phase and in terms of adaptations for the main study, we wanted to improve our participant retention because the 28% attrition was high. And we also wanted to improve the quality of the data collection. So we did a few things to that carried into this larger main study. We modified the CHW and site staff training, and we structured the CHW supervision on site. At the health department, instead of having just one CHW full-time, we hired 2 part-time CHWs because in the feasibility study, the one full-time CHW left the study before it finished. So we were left with no one to give the intervention. And so we wanted to figure out a way to do that in a way where we could have 2 part-time persons who could do the recruitment and deliver the intervention, CHWs, intervention in such a way that they could cover for each other. And then the other thing that we did is we tried to include elements that would allow the CHW to be more integrated with the clinical staff at the community health centers. And then we included more engagement and data monitoring by us as the research leads at UNC. So those were some of the things that we did. So in the second change study, we went to another set of counties, Edgecombe, Nash, they're adjacent to each other. But again, high CVD mortality rate. Edgecombe is particularly high. So 58% of Edgecombe residents self-identify as African American or Black, and the county had a 21% poverty rate at the time. We enrolled 255 participants, and the eligibility and recruitment procedures for this change study was the same as in the feasibility study. All right. As you can see here with our sample, we consented 255, and all of them started the program, which already is an improvement. Of the 255 that started, 222 provided follow-up data. So that's an 87% retention. Like in the feasibility study, most of the participants were non-Hispanic Black by self-identification. 72% were female with a mean age of 57 years, and over half reported having an educational attainment of a high school degree or less. In terms of the risk factors, 84% were diagnosed with hypertension, 55% with diabetes, that's not on the slide. 65% had hypercholesterolemia, and about 20% were current smokers. So a little bit more smokers in this group. The mean baseline blood pressure for this sample was 127 systolic and 75 diastolic. So much more controlled hypertension than in the first feasibility sample. All right, these are our outcomes, implementation and effectiveness. So overall, most of the participants for this sample were recruited from the community health center, 54%. In terms of the program uptake, we had 3.5 on average. Participants received 3.5 counseling visits, and remember there are 4. And then the average duration was 70 minutes and 2.7 booster calls on average, with an average duration of 10 minutes. So we had, again, a slight difference between health departments and community health center in this study, where the health department participants completed 89% of all their planned visits, while the health center participants completed 94%. So much better program uptake. And again, in terms of what topics participants chose to focus on, it was the same as before, healthy eating and then physical activity. But smoking cessation came as the third topic, in terms of ranking, topic of interest, with medication in the last, in terms of focus and priority. In terms of the referrals, about 30% of the referrals that were given were actual participants received services from those referrals, which means they followed up on the referrals and received those services. But only 30% of the referrals actually resulted in services being received by the participants. In terms of our effectiveness, there were no significant changes in weight, which we really don't expect. This is not a weight loss program. Blood pressure changes were smaller than that in the feasibility study, but again, they started at a lower average BP. In terms of the self-reported dietary and physical activity changes, you can see here that the changes were similar to those in the feasibility study. So, but significantly so. One of the things we found here is that after adjusting for sex, chronic conditions such as diabetes and hypertension, and then education, the one factor that sort of was associated with larger pre-post changes in these outcomes was age, so that the older participants had the bigger changes in these self-reported dietary physical activity outcomes. All right, so those are the two change studies. I've just given you an overview of what we found in both of them. These are the key takeaways from going through that feasibility phase to the main study in terms of our implementation outcomes. We were able to improve those outcomes with the changes that we made. And the changes that we made had to do more with pre-implementation planning for staff turnover, CHWs and supervisory training improved on the site level, and then our ability to integrate the CHW into the healthcare delivery team at the community health center was also improved. And so that's encouraging to the extent that the more we can sustain these community clinical linkages to support chronic disease management, the more significant impact we can have, particularly in communities where you have a large rural population for which we know all the barriers to healthy living, and particularly in those rural settings where you have the intersection with rurality and race. So to the extent that we can keep these linkages sustained, there's a potential for true public health impact. All right, so that's a review of the studies. I have 3 personal like success stories that I can share very briefly, and then we can move into the question and discussion phase. One of the things we did with the study is we gathered success stories from participants, and we also, at the end of the studies, had community gatherings where we presented the results of the study back to the community at the sites, and we invited the people who gave success stories to come in and meet the community members and the site members and talk about their experiences. So I will tell you that the dissemination toolkit has a lot more success stories than the 3 I'm going to just briefly overview here. And that's one place that you can find additional stories from our study participants. What's consistent with the 3 success stories I will just share briefly with you is that they all mention how the community health workers supported them throughout their behavior changes. And it's all the social support that comes from community health workers and makes the difference in people thinking that they have what it takes to make the behavior changes that they want to make. So this is our first success participant. And Mr. Hall, I'll just give you the brief version of what you see here. Again, this is in the toolkit. So his change was to decrease the amount of cigarettes he smoked. He says he was smoking a pack and a half a day. But this is the clicker. He couldn't walk to the end of the driveway without getting out of breath, and he loved to hunt. And so his smoking was getting in the way of something that he really enjoyed doing. And so that was his motivation to change. He met the CHW in the community at the bank, and she told him about the study. And what he liked about the engagement with the CHW as he became a part of the study was that he said, her pushing me along made a difference. So that's where the social support comes in. What he also mentioned was the CHW, instead of calling him once between those home visits, she called him twice a week. So that was additional support that he got from the CHW. And she was also able to help him problem solve around, he was cutting back on his smoking, but he was starting to gain weight. So he didn't know what to do about that. So she encouraged him to get more exercise. He did that. And by the end of the study, instead of being at 1 to 2 packs of cigarette per day, he was down to 1 pack a month. And what he said was that, it was that constant encouragement and also helping guide him through the whole process of making that behavior change. He also said she also helped him with his coming up with a routine for taking his meds. And so at the end of all of this, he was feeling better and he could do the things that he enjoyed doing. And then the next person, she had uncontrolled diabetes and she really wanted to make changes in her lifestyle behaviors. Why? Her why was she wanted to see her first grandchild. And so she knew she had to make some changes. And she calls her CHW her angel. So she is the whole idea of a good angel and a bad angel. The CHW was her good angel. And what she valued about that engagement with the program, which included the CHW, was that she liked the materials and the fact that the options they gave were easy, things that she could do and things that she could do in her home. If you know about rural settings, there are no sidewalks, so you have to come up with other solutions. And she says the key to her success was having a CHW who encouraged and believed in her throughout the program. Those are her words. So she did the dietary physical activity changes that also resulted in weight loss for her. The last one is another female participant. She was hospitalized and she left the hospital with a sheet that said, limit your sodium to 200 milligrams per day. So she was like, who is going to help me do this? She talked to her doctor to find a nutritionist that she could talk with, but instead he referred her to the program. And so she was able to use the materials from the program, learn about actually cutting the sodium in her diet and doing other behavior changes that she would not have thought of doing had she not joined the program. So one of the things she mentioned in her success story is not only that she made the changes, but her family are making the changes, the healthy changes in terms of the diet as well. So those are just 3 examples of participants who give a face to some of the results that you saw. So as I mentioned, this dissemination toolkit is available. There are 3 links there that give you access to the things that the public's tax dollars funded. So these are available and you can download them using the links that are here. in terms of our research partners for these two chain studies, they are listed here, the actual sites in those 3 counties. And then on this slide, you have the publications from the chain study, as well as 2 more recent publications that deal with the Med-South dietary pattern and program that we've used in other studies, looking at really trying to get chronic disease risk reduction more scaled up in our state. And that's all I have. So I thank you for listening to what I had to share, and I think it's now time for you to ask questions, or I'll turn it over. I'll stop sharing.
Thank you, Dr. Carmen. That was an incredible program, and I think all of us agree with those success stories, that it was really nice to hear their personal connections with the program and to hear about what helped them, and that being the community health workers' impact in the program. So that was really nice to hear. We did have a few questions in the chat, and we'll probably go over some questions in 5 minutes and then save 5 minutes at the end for the post-echo survey. So Louisa asked, how many participants per community health worker?
Okay, so in the main study, the larger one, we had 1 CHW for 58 participants at the community health center, and it was like more like 1 to 2 in the health department because they had two community health workers. So I don't think it was burdensome, given the fact that the community health worker for the community health center was full-time.
Great. And Nicole asks, what questions did you have in your initial assessment? How long was the assessment?
The brief assessment? Which
I think
assessment?
yes.
Okay. So the brief assessment is actually how you begin the session once a nutrition topic is selected. And none of the assessments are over a page long. So they're not long, and what they're very easy to answer. And the fact that the participants, once you tell them where things land and what it means, they can also see where they are in terms of their behavior changes and then make a decision about, of all these things, what do I want to start with? So they drive the change that they make.
And let me see. Sharma asks, what did you do to have such a high retention rate?
I really, I really think the CHWs were well trained, and they were well trained, and they came into it already trained and knowing how to engage with their community members. One of the things we do with all of our studies is we tell our facilitators, whether they're CHWs or professionally trained, you are not teaching anybody. These are adults. You're going to treat them like adults, and you're going to use a more person-centered approach to have a conversation. That's what you're doing. You're having a conversation with someone to do a thing that they said is important for them to do. That's all you're doing. So have those conversations in a in a way that says, you're in charge. I can help you figure this out, but you're the driver here. And that's why I think it works. And the other part is the materials are also with that same tone. They're not in your face. It's like you choose. There's many of options. Which one do you want to start with? So I think it's all behaviorally sound and it's consistent with adult learning theory. So
yeah. Awesome. And Lawanda asks, will this study be continued or revamped anytime soon?
So we've already made edits to it so that because every 5-6 years we're looking at what does the research say in terms of what should be recommended. And so we always update based on the current evidence. We just finished another 5-year study where we scaled this program up into 19 health departments across North Carolina, and that's one of the publications that you have. And every year we do trainings that are online for how to implement the MedSouth program. And so if you go to our website, you'll see, the trainings that have happened. We've already had one for 2025, and we're maybe having one for 26. So we try to make sure that we are letting folks know that this program exists, and we provide training virtual for implementing the program. And you can register to use the materials. There's no cost. You just have to print them and do the other things for implementation, but they're available.
Yeah. We do have a large representation of community health workers in our ECHO series, so I'm sure all those amazing resources will be of great help.
Yeah.
And I think we also had some comments about appreciation. Allison said, I work mostly with Latino men, so I appreciate your inclusion of the story of the male participant. Men can be harder to engage. And T says, it is always amazing to see programs that engage community health workers to show how effective we are at engaging participants, as well as sharing ways that they can improve on areas of difficulty along with the community health worker.
Good. What was I gonna say? We also have the materials in Spanish. You mentioned Latino men, so the materials come in both English and Spanish, and we have the cookbook in English and Spanish. So those are all available. Yes. Okay. All right.
And yes, I see a lot of comments about the copy of the slide deck, the resources. I dropped a few links to some of the resources, but I'll also upload the slide deck on iEcho and share it via email. So thank you so much. And Shelby, you had your hand raised. Do you have a question?
Yeah, I do have a question. So on one of the slides where you did implement the program, you did state that there was a total of, was it 255 that were initially enrolled, but at the end of the program implementation, there was a success rate of, was it 238?
222 of 255.
Okay. And I just wanted to know, how did you gauge that fallout for the program? Was there any type of, was it just non-contact or just non-engagement into like the CHW assessments and assisting them, or how was that? How were those numbers?
Yeah, so remember, we're targeting a population that they have survival mode issues in their day-to-day. So for this type of program in that context with a 13% attrition is absolutely amazing. It's better than the average CHW delivered program in the literature. So and imagine the feasibility study, it was 28% attrition, and we dropped that down to 13 when we got to the bigger study with all the adaptations we made informed by the feasibility study. So those outcomes are really good if you look at the literature. And there's no intervention that you have that targets adults who live in socially difficult settings that has that high retention. And I think it's because there was a special engagement with the CHW and the participant for that to happen. If you notice, the sessions lasted longer than they were supposed to, which means people were chatting. And sometimes that's all people want. That social engagement is also health promoting. And I think we forget that. People want an engagement with another human being. But what tends to happen is you don't get that unless you're in a different social class. You get a screen or a virtual thing. But it's that human engagement with a person who is from your community. It's a similar other that's having a conversation with you about, I know you can do this. here are some ways that you can approach this. That's, I think, what works. I think I gave you a longer answer than you intended, but you can see what drives me to do this work.
No, that's fine. I
Yeah.
just wanted to know like what was deemed the fallout portion of it. Was it like
Yeah.
they just exited the program, or they just stopped contact as like
Yeah, usually that's a unable to contact type of thing where something happens with that person that attending this program is no longer top priority. So it happens.
All right. Thank you, everyone, for the amazing questions. I know we've had a lot of rich conversation, and Dr. Carmen did share her email address
Yeah,
in the
please
slide.
find me if you have questions. Yeah.
Yep. Awesome.